at the University of California, San Diego. Born in Ukraine, trained in the UK, St. George's Hospital Medical School, University of London, and then working in the US for many, many years. And I serve as a vice president of ICU-DDR. All of these kind of titles, they actually, frankly, don't mean anything to me. At my age, I really don't care anymore. But what I do care about is in teaching people, and this is what I do, and I do it not just in the United States, I do it all over the world, in teaching people, particularly in addiction medicine, like in any other field of medicine, you either do it right or you don't do it at all. Because training people is a very responsible thing. I work with medical students, they're very young kids, very bright. You can instill in their brain anything, all sorts of good things and all sorts of bad things. But anyway, I take teaching and training people very responsibly. We all know that the addiction training and addiction teaching is insufficient all over the world. I don't know about your countries, but in the United States, we are not doing a good job training physicians, psychologists, law enforcement people, policymakers in anything relevant to addiction medicine. Even in places where we do have some teaching hours or teaching curricula, in 99% of cases, teaching is didactic and frankly quite boring. If you look at the literature, the adult learning literature, actually you will see quite a lot of evidence that adults learn pretty much like children. There is not much difference. Adults learn more when there is interaction. They learn better and more sustainably if they play games, very similarly to children. The content is different, the complexity is different, but the processes are quite the same. So one of the things that I'm trying to do is to deviate from a typical, traditional lecturing, I'm a professor, you are my students, I'm smart, you are not. I don't like any of these things. This is not effective. It's not because I don't like it. This is not effective. It's not sustainable. So I'm trying every time I have a chance to deviate from traditional teaching, traditional didactic lecturing, I'm doing that. And I'm thinking constantly about ways to change the teaching to make, my teaching to make it more sustainable. So when I was thinking about this presentation, I was thinking about how I'm going to talk about the converting didactic presentations into interactive and making some fun. And then I said, why should I talk about it? Let's just do it. Let's do it. You will experience it yourself. Would you agree with me? I can guarantee you, you will be doing some work now with me for the next 40 minutes. You have my word. I can guarantee you I'm not going to ask you to do anything that is emotionally or physically unsafe. Okay? You have my word for that, so you don't have to worry about it at all. All right, so now the first thing I want you to do, I want you to look around the room and find one person that you don't know, and this should not be the person on your left or on your right. So you will need to get up. And do it quickly because we have very short time. Please find one person that you don't know and sit with this person. Folks, grab your chair and sit with this person. Do it. Please sit down. When you found a partner, please sit down with your partner. You may want to, I will give you 30 seconds, just introduce yourself. Do you have a partner? No. Oh, you're translating. Wonderful, sorry. Perfect. Okay. You all have a partner? Introduce yourself, you have 30 seconds. Share as much information as you feel comfortable sharing. Now, Jalal, will have fun. We will have fun. Okay. Okay, folks, show me your hands. You're ready to work with me. Please show me your hands. You're ready to work with me. You're ready to work with me, right? Okay. All right. Folks, now I need your attention. There is a very, I need your attention for a second. There is a very popular TV show, not just in the United States, I know that in many countries in the world for quite some time, for many years. Who Wants to Be a Millionaire? Do you know this game? You all know. Is there anybody here who doesn't know the game? Who had never seen this show? You don't know it. Okay, very quickly. There, usually on TV, you have participants playing with the computer or people. The computer will show you a question or a statement with 4 possible options to answer. You will have some time to think about it, and then you will give the answer, whatever answer you believe is the right one. You have lifelines. If you're hesitant, if you're not sure, you can do 3 things. You can do 50-50 then, so then we will eliminate a half of the responses. Or you can call a friend, or you can ask the audience. These are your lifelines. So if you're hesitant, if you don't know, if you're not sure, you always can have help. Is that clear? Okay. Now, you will play this game with me. We'll play it together. And you will be playing with your partner, sitting here. You see there are 2 chairs. You are the only 2 people who will be able to talk and discuss, okay? So you will have to communicate with your partner. For the rest of the audience, unless they ask you for help, you will be quiet. This is kind of impulse control test. You will be, you will stay quiet. I know it will be difficult for you, but try your best, okay? Is that clear? For every question, we'll have a different couple sitting here. So every time we have a couple, we have a question, answer the question, go home, somebody else will come here. Is that clear? Okay, who is my first presenter? You will do it. Please come here. Please come here. First, you will need to introduce yourself to the group. Who are you? Where are you from? Briefly, introduce yourself.
Hi, good morning. I'm Verna Felipe. I'm from the Philippines, but I'm based in the US right now.
Wisdom Croquet from Nigeria.
Wonderful. Please take a seat. Keep the mic because you will need it. What is your question? You can use any lifeline you want, because I do not want you to lose, and I can guarantee you that you will win, okay? All right. You don't have to worry about it. Okay, you ready?
Yeah.
Good. Where opioid receptors are mostly located? Brain and spinal cord, brain, large joints, intestines, or everywhere in the body. You can discuss. You can talk. Remember, I'm just reminding you, you have real experts in the room. So if you are not sure, there are people who are the world best. And you can ask help, you're entitled. Yes, you're ready? You go 50-50. Smart idea. Okay, I'm taking out A and B. So you're remaining C and D. My flight is tomorrow. I have time. I'm not in a hurry. So, with letter D. Okay, that's an interesting concept. Let's think about it, folks. When people are in opioid withdrawal, what do they experience? Joint pains, diarrhea, right? Anxiety.
Similar to arthritis-ish.
Similar, yeah, very like flu, severe flu, but there is significant pain in the joints. Usually that's what, and do you know why? Because the opioid receptors are there. Don't tell anybody. So maybe you may reconsider your answer. C, this is the right answer. Good for you. Okay. Who's next? No, hold on. You will need to select the next couple. You're selecting these two people. Please come. Introduce yourself, please. You don't... What you can't see? You can move here. Just move here. Yeah. Okay, introduce yourself, please. Your mic is not working, I guess. Yeah. Yeah.
I'm Salman from Institute of Clinical Psychology, University of Karachi.
And I'm Susanna, and I'm from the International Society of Addiction Medicine.
Very nice. Please take a seat. Are you nervous?
Very.
Alcohol mostly affects what neurotransmission pathway? Endorphins, serotonin, GABA, or norepinephrine? I don't know, nobody here had ever tried alcohol, I know that, for sure. They have no personal experience, but from the literature, you might have heard. So what do we think?
We're gonna go 50-50.
You're going 50-50. Okay. Smart idea. I'm taking out A and B. So it's either C or D.
So, final answer,
Yes.
C, GABA.
C, GABA. Give them a hand. It's right answer. Okay. Alcohol is a brain depressant. GABA, gamma aminobutyric acid, is the major inhibitor in neurotransmitter in the brain. That's why alcohol, benzodiazepines, barbiturates, they all work on GABA in a very similar way. Wonderful answer. You're very smart. Please pick another group, another couple. Come on, guys. Come on. Please introduce yourself. Your mic is not working.
Hello, everyone. I'm Tiha Lim from Myanmar.
From Myanmar? Wonderful.
Yeah. Hello, I'm Aung Yunai from Myanmar as well.
Okay, and they don't know each other. Okay, please, take a seat. All right, here is the question. The typical daily dose of methadone for maintenance treatment is what? 80 to 120 milligrams, 120 to 140, 30 to 60, or 160 to 200 milligrams. What is the typical average dose of methadone for maintenance? Yes. 80 to 120. Is this your final answer? Beautiful, because this is the right answer. Pick somebody else. Pick somebody else. Don't turn the mic off. Just pick somebody else. Okay, so from that side. These two, please come in. Come in, guys. Come, introduce yourself, please. It's on.
Hello, my name is Nami Kim from South Korea, and this is my son,
Oh, you definitely don't know each other, yeah. This is, folks, this is a teachable moment, by the way. Because you remember the instruction, find somebody you don't know.
Oh, really?
Yeah. So when our patients do not follow our instructions and we get really upset, think about, do we follow the instruction? Okay? Okay, here's the question for you. What medication is used in treatment of amphetamine use disorder? Methadone, buprenorphine, naloxone, or there is no medication? You can discuss. You're the only ones who can discuss. They are doing the impulse control test. You are discussing. D, final answer. No medication, you mean? This is your final answer. No pressure. Good, and this is the right answer. Okay. Pick somebody else. Please pick somebody else. Come on, guys. Please introduce yourself. Get the mic.
Hello, my name is Eva. I'm from Atmajaya Catholic University of Indonesia.
Hello, my name is Ala. I'm from Ukraine. I'm a psychologist.
Wonderful. Please take a seat. You will need the mic. Don't get rid of it. You will need it. Okay, here is what the question is. Heavy alcohol users usually develop cross-tolerance to what? Cannabis, coke, methamphetamines, or benzodiazepines? You can chat. You can chat. You can talk. You want 50-50. Okay, that's wonderful. I'm taking A and C out. So the remaining answers are B and D. Do you know what is cross-tolerance? Let's start with that. Cross-tolerance, when people take 2 or more substances, they increase the effect of each other. So 1 + 1 = 7 in that case. So that's one. I don't want any heart attack here. Calm down. Calm down. You will be fine. I can guarantee it. D, benzodiazepines. Okay, I will tell you right away, this is the right answer, but why did you decide it's benzodiazepine? I'm just interested in your thinking. Why? This is the right answer. Use the mic. Because cross-tolerance happens when people use substances that belong to the same class. Benzodiazepines and alcohol, they belong to the same class of brain depressants. And this is the only, out of these 4, this is the only substance that belongs to the same class like alcohol. So you gave the right answer. Very smart idea. Please speak to other people. All right. You're Dr. Risa, I guess. I know you for many years. Please introduce yourself.
Hello, I'm Riza from Indonesia. I'm a clinical psychologist.
I'm Roshan. I'm from India. I'm Associate Professor of Psychiatry.
Wonderful. Okay. So here is the question for you. This is actually a statement. It's not a question. It's a statement. People can develop substance use disorder after a single drug use. This is a statement. True. False. Only if they use opioids. Only to amphetamines. So the statement says people can develop substance use disorder after a single use. What do you think?
We try to be confident.
Okay, that's a good idea. Your answer is B, false. Okay, I will tell you right away that this is the right answer, but why did you decide it's B? You're not using your mic.
Choose disorder, right?
Yeah.
So it has to be used regularly and have some.
Beautiful, brilliant, brilliant. Because the definition of substance use disorder is a repetitive, maladaptive, and compulsive use despite problems. So compulsive meaning out of control, but repetitive. Repetitive does not fit the criteria of single substance use. So your answer, false, is the right answer. Very good idea. Brilliant. Pick somebody else. Introduce yourself, please.
Hello, I'm Christiana. I'm a psychiatrist from Indonesia.
I am Charles from Nigeria.
Wonderful. Please take a seat. Don't turn the mic off. Keep it on because people need it. What? Oh, it's automatically. So this mic has antisocial personality disorder. Okay. All right. Substance use disorders are genetically what? Determined, influenced, non-related, or neutral? This is the hell of a question. Yeah, I know that, but I mean, there is an incremental increase in the amount of money people can win, so the complexity of the question goes up. So,
We go with B.
you're going with B, influenced. This is the right answer, but why did you decide B?
Because genetical disposition is not the only determinant of substance use. There are other factors.
Brilliant. Brilliant. Genetically determined condition means that if you have a bad combination of typically recessive genes from both biological parents, you will develop the disease no matter what. Example, the cystic fibrosis, the Huntington disease. I mean, it has nothing to do with your lifestyle, education, nutrition. It's unfortunate. You got a bad luck, that's it. This is genetically determined. A genetically influenced condition means that if you have a family history of a problem, you're more vulnerable to develop the same problem like diabetes, breast cancer, hypertension, some forms of asthma, but this is not 100% because there's some other factors too. So your answer is absolutely accurate. Good for you. Pick somebody else. Come on, gentlemen. Thank you. Please introduce yourself.
Hello, good morning. I am Sajid Iqbal. I am from Pakistan. I am a clinical psychologist.
I'm Valentine from Nigeria. I'm a neuropsychologist.
Wonderful. Please take a seat. Pharmacotherapy of substance use disorders is effective most of the time by itself, most effective with psychoanalysis, most effective if combined with psychosocial treatment, or not effective unless adjusted for body mass index.
Absolutely. We go for C.
You're going for C?
Yes.
Absolutely.
Yes.
You're convinced?
Yeah, absolutely.
Good for you. Okay. All right. Pick somebody else, please. The two ladies. Okay, ladies, come in. Please introduce yourself.
My name is Irina Pinchuk. I am psychiatrist from Ukraine.
Yeah, and I'm Gladys from Kenya as a counseling psychologist.
Wonderful. Please take a seat, ladies. United Nations International Drug Conventions commit governments to implement a prohibitionist regime. This is the statement. False, true, only for opioids, or only for stimulants. Can I give you a hint? Ladies, can I give you a hint? Right now, it's just pure luck for you. Dr. Gerald Tawfiq, who is the president of INCB, is here in the room. I guess he knows the answer. Because this is what he's responsible for, okay? So if you have any level of hesitation, if I was you, I would call a friend. I would call. Yeah.
We're asking 50-50.
You want 50-50? Excellent idea. All right, I'm taking out C and D. Okay.
Yes, so we are going for A, that is false.
You're going for A, it's false. And this is the right answer. Good for you. Gerald, they didn't need you.
Yes, we are picking the group at the end.
Say it again?
Yes, the group at the end.
The two gentlemen?
No, the gentleman and the lady.
The gentleman and the
Yes.
lady, please. Wonderful. By the way, the UN conventions never said any prohibitionistic approach. Never. The substances are controlled. Substances are dangerous not because they're controlled. They are controlled because they're dangerous. This is something that many people, even people who work in this field, don't necessarily understand, because very few people have actually read the 3 international conventions, and it makes sense to do. It does. Please introduce yourself.
Dr. Jawad, I am a clinical psychologist from Pakistan.
Wonderful.
Yeah, my name is Lekina, psychiatrist from Cambodia.
Wonderful. Please take a seat. The most commonly used drug in the world is what? Heroin, amphetamines, cannabis, or coke?
C.
C, cannabis.
Yes.
You are convinced?
Yes.
You didn't even want to discuss with your partner?
We discussed.
So you're ignoring her?
No.
Okay.
No, she.
You know, this is an old psychotherapeutic trick. Capitalize on guilt. So you instill guilt and then you capitalize on that. This is not what I'm doing, but there is a trick like that. Okay, so you're convinced? The answer is C, cannabis.
Yes.
And this is the right answer. Thank you. Pick somebody else. Yes. I deliberately did not put alcohol in here because it was pretty clear. That would be, and tobacco, that would be pretty clear.
Hello
Right,
everyone.
right, but
This
alcohol
is Salim Abbas,
is
clinical
not an illicit
psychologist from Pakistan.
I am Nurul Zaman from Pakistan.
Wonderful. Please take a seat, gentlemen.
We never met.
Okay, here is the statement. The data suggests that use of cannabis increases violence. This is the statement. True, only in some countries. False, only in high doses. The statement is that the use of cannabis increases violence. Is this true? It's not true? Or?
50-50. We'll go for 50.
You want 50-50? That's a brilliant idea. I'm taking B and D out. That's a wonderful idea.
Sir, A.
Say it again?
A. It's true.
A, it's true. You think the use of cannabis doesn't increase the violence. And you're certain.
Yeah.
You're sure.
Yeah.
And you don't want to reconsider. I'm just asking. I mean,
No.
well, folks, this is important because particularly now there are a number of countries and a number of states in the United States that legalize the controlled market of cannabis. California is one of them. I'm from California, is one of them. And this is a quite important issue, whether we should expect increases in violent behavior. If you look at the literature, the use of cannabis may result in a number of different difficulties for people. Sometimes the difficulties are pretty serious. There is no evidence that the use of cannabis by itself actually increases violent behavior. There is no evidence for that. So it's C, of course. Of course. Thank you very much. Pick somebody else. Pick somebody else, guys. Gentlemen, you need to decide who is next. Okay. Introduce yourself. Are you having fun, guys? Okay, good.
Hello, my name is Imelda. I'm a psychiatrist from Jakarta.
Hello, my name is Guillermo Castaño from University 6, Colombia. I am physician at Injury.
Wonderful. Take a seat. And here is a question for you. Which of the following is not a symptom of substance use disorder? Please pay attention. Not a symptom of SUD. Unsuccessful attempts to cut down, giving up important social activities, denial and lack of insight into the severity of use, or the use despite recurrent substance-related problems. I would suggest you to think about the ICD-11 or DSM-5 because they're pretty similar from that perspective. Which of these four is not a symptom? They are not nervous at all. I'm looking at their faces. They look so calm and composed. So,
I think it's C. C.
C. This is your final answer.
Yeah.
Wonderful, because this is the right answer. Good. Pick somebody else.
Over there, and at the end. No.
The two gentlemen?
Yeah, the two gentlemen.
Come on, guys. Let's talk. Get the mic, introduce yourself. Tell us the most embarrassing story of your life. Please, go ahead.
I'm Charles from Nigeria. Nothing embarrassing.
No.
I am Pras, psychiatrist from Indonesia.
You're from Nigeria, from where in Nigeria?
University of Nigeria.
University of Nigeria. I've been to Nigeria, Abuja, Lagos several times. Yeah. Okay. Here is a statement. Drug use in school children can be prevented by providing lectures about the danger of drugs. True, false, only in middle schools, only if provided by Igor.
guys.
It's a successful impulse control right here.
This audience
Okay.
is,
You want to ask the audience?
the audience is evil.
Say it again.
They are evil.
You have
So-
lifelines if you want to.
I would think it's A, right?
Say it again.
A,
You want to say A.
yes.
How about you? Do you have the same opinion?
Yeah, it is same.
You do?
Yeah.
Okay. Are you familiar with the United Nations International Standards of Prevention? Have you heard about this document? The United Nations in 2016, the UNODC, in 2016, they had done a tremendous amount of work, doing, in fact, a systematic review of thousands of studies on what type of prevention activities in schools actually can give you some effect and which ones are ineffective and we need to just stop doing that. What they found, and actually this is not the only finding, many other studies have found pretty much the same, that giving kids classes about how bad it is to use amphetamines as if they don't know, doing that, actually the impact is zero. And the most effective prevention programs are the ones that actually don't deal with drugs at all. They deal with assertiveness, decision-making, problem-solving, parenting, and many other communication skills, and many other things. So the answer to this statement is actually false. B, and in your countries, if you are asked to do prevention and go to school and tell kids that they should not be doing heroin, please don't waste your time, okay? Wonderful answer. Pick somebody else.
Thank you for identifying.
Please come in. Sherry. Okay, we have only two
Thank you.
questions
Hi,
left.
I'm Sherry Larkins. I'm from the University of California, Los Angeles, and I'm a research sociologist.
I am Abdul Wahid Tabish, psychotherapist from Pakistan.
Wonderful. Please take a seat. Here is the statement. That's an interesting statement. Use of Ritalin in children with ADHD, attention deficit hyperactivity disorder, increases the chances of stimulant abuse later in life. This is the statement. True, false, only in high doses, only in girls.
Okay, we're going to use a lifeline.
Please, which one?
We are going to poll the audience.
Ask the audience. If you trust these people, please ask the audience.
If you think this is true, raise your hand. Okay, we have one. If you think this is false, raise your hand. Ooh. If you think only in high doses, raise your hand. If you think only in girls, raise your hand. Okay, we're going to go with the audience, B.
B. And this is the right answer. Thank you, audience.
Thank
Pick
you,
somebody
audience.
else.
We just
Folks,
won
this-
500,000.
Yeah.
I'm going to have Lori Crum and Shelley.
Okay.
Okay, Shelley and yes, the gentleman, yes.
Please come
You
here.
look like you know answers.
While
Come on
they're,
down.
while they're coming, folks, there is a very common belief, even among physicians in the world, that children with real, properly diagnosed ADHD, if you treat them with Ritalin, which is an amphetamine-like substance, that will increase the chances they will start using Ritalin later in life. Absolutely no evidence for that whatsoever. It has been studied in hundreds of studies. So if we don't treat ADHD, that will increase actually the chances for all sorts of problems. All right? Please introduce yourself.
My name is Musawir Ali. I am from Pakistan. I am a clinical psychologist currently doing PhD.
Wonderful.
Here's my partner.
I'm Shelly, a psychiatrist from Indonesia.
Please take a seat. This is the last question. It's $1 million question, folks. They must be pretty brave. Okay. That's a dramatic music. Should be dramatic. $1 million. If they lose it. All right. What is the cost effectiveness of drug demand reduction return on investment? 1 to 7 in dollars. 1 to 3, 1 to 15. DDR is not cost effective. A return on investment means if you invest $1, how much are you going to get in return? That's what cost effectiveness means. And again, this is the average number. Globally, for the world, in different countries, things are different. This is the average, the median.
So we want to ask the audience.
Please, go ahead, ask the audience.
And after this, can also choose 50-50, yeah? Oh, no, only one.
Well, first, ask the audience and see what will happen.
Okay. Okay, so audience said that I better to choose 50-50 first.
Okay, that's smart. I'm taking C and D out. So you
C
have
and
A
D.
or B.
Oh, A or B. So for A, how many?
How many of you say it's 1 to 7? That's option A. And how many of you say it's the option B, 1:3? What to do now?
Cannot ask Igor. Cannot.
Can you what?
Cannot ask the host. Cannot.
Can you ask me? You can, yes.
Again.
That's fine.
Call a friend. Yes. Igor.
You want to call a friend?
Yes.
My phone is busy.
So do you have any other friend?
I am just looking for the answer is point B.
Seven. 1 7? B? 1 with 3?
You go with the B.
Yeah.
Well, this, again, there might be different readings and different ideas. In general, globally, all over the world, different countries are different. But the average, the mean savings, for every dollar invested in drug demand reduction, we are saving $6.50 to $7 in return. This is the average cost effectiveness. Even the greediest Wall Street banks will consider that a good investment, okay?
Thank you.
You just won $1 million.
Okay. All right, folks. Thank you. So I just wanted to show you a different way of teaching. And it does have some educational value. I work with my students. I have tons of these kind of things developed over many years. And by the way, this is just a PowerPoint file. There is nothing unusual. It's an animated PowerPoint file. You can change questions. You can do whatever you want. It's just simple PowerPoint file. I have tons of things like that. Every time I'm teaching and training students, residents, people in the United States, people outside of the United States and other countries, I'm trying not to lecture folks. Lecturing is the least effective way of technology transfer. Sometimes it's important to give people instructions. So you might need some lecturing didactic part in your teaching process. But if the only thing we do is lecturing people, the impact is not very good, and the result is not very good. And this is not because I said so. Look at the educational literature. It's been studied many, many times, and the finding is pretty much the same. Every time, those of you who are involved in training and teaching, every time you have a chance to be creative and to find a different way and avoid lecturing as much as possible, I would strongly suggest you to do that. That will increase the sustainability and will increase the impact of your teaching, and it will be fun. All right, questions, comments, ideas, anything you want to share? We have 2 more minutes. Yes, please. Okay, the question is how to develop skills. For skill development, you need even less lecturing. Let me give you an example. I'm a professional jazz musician. I play saxophone, jazz saxophone for many years. If you want to learn how to play saxophone, definitely I need to give you some instructions, okay? I will show you the instrument, I will give you some instructions, what does it mean, what to push, what not to push. But are you gonna play from that? No. You will learn more about playing. So if you really want to start playing, I will give you a saxophone, you will play for me, I will give you feedback, will correct your bad habits, you will play again, I will give you supervision, you will play again, and relatively quickly, you will become proficient. I can guarantee it to you, okay? So when we build skills, you need even less lecturing. You do need some instructions, but you need to help people to practice it, and practice it with your supervision, with your guidance, with your support, and then they will become proficient. Make sense? Yes.
Have you had much difficulty in meeting learning objectives? Because, you know, the universities come up with a set of learning objectives that you have to have for that particular module of training, right? And doing something like this is fantastic, but you won't necessarily always be able to cover the learning objectives. Do you include something else with that to be able to cover that?
The question is, do we meet learning objectives using this strategy? First, this is not the only strategy that I use. Every time I have a chance to do it, I do it. I'm doing it, but sometimes we give lectures and we give some skills and we test people. Secondly, you can accomplish anything in terms of your objectives, even if you do not lecture people at all. If you are creative and change the strategy, the educational strategy, you can still accomplish the objective. This could be a game, this could be a practice, this could be also problem solving, could be a problem solving discussion, could be a marathon, something that we use. My university, thank God, is quite liberal, and it gives the faculty the opportunity to experiment with different things. And if the students are happy, and if they meet the criteria and they pass the exam, so apparently we are doing something right. And we do meet the learning objectives. Good question. Anything else, folks? Yes, please. Mike.
Thank you, Igor. So I have 2 questions. The first question is, for skill developing, maybe you can do the role play, or not the role play, but the real case, the real patient with the student. And then I would like to ask, is it possible for me to cut the interview? Because it's very difficult in the clinical setting. If I cut the interview, so the patient maybe will be feel uncomfortable, but I want to fix the interviewing of the student. Yeah. And the second question is, if you feel very boring to give a lecture, to teach the student, what will you do then?
What is the second question? If
you feel boring,
yes.
Burn out because giving the lectures to the student, sometimes I feel like that because it's very tough.
So what's the question?
Yeah, what will you do then?
What would I do?
Yeah.
I would do this. But let me answer first question. In terms of interrupting the interviews, this is the reason why we use standardized patients. Before we actually let the students and residents work with real patients, we use the standardized patients. These are actors, very well trained, and they present cases. During this practice interview student with this standardized patient, I can interrupt the process at any time and give feedback. We can change things, we can modify things, we can go back and rewind the whole thing. And we do it all the time until my students or my residents feel pretty comfortable to work with a real patient. And then they work with a real patient. When they work with a real patient, I do not interrupt. speaking about, you know, boring or not boring. This is not about me being bored. I have my own impulse control problem and I'm getting bored pretty easily, but this is not about me. This is about being effective in your training, in your teaching. And what we know from the literature, if people have experiential teaching rather than didactic lecturing, that will give you more sustainable result, and usually the impact is greater. Yes?
I'm wondering how I can adapt this to, most time we have a class of 100, 120.
Mm-hmm.
And the number, and then you have a space of 1 hour. This might not cover the curriculum that you are asked to deliver within that 1 hour.
Well, it would be difficult to do with 100 people, at least for me. I would experience some difficulty. The group is too large. You can still do some small group discussions. You can do some small group role play with the assignments for each group, small group member. You can do a lot of different things, but working with 100 people at the same time is difficult. Okay, folks, we need to stop. I want to thank you. I just wanted to illustrate a different way of teaching people that has some educational value and still has some fun in it. Thanks a lot. Good luck to all of you.